Eric and Vadim, why don't we go ahead and get started?
Let's do that. Okay.
Hi, everyone. Welcome to the 2020 Evolution of Telehealth, Lessons Learned and Strategies to Optimize Opportunities. There hasn't been more affected by the COVID crisis after COVID. And this is a great opportunity for our distinguished speakers to present information and provide a good primer about the different items that have been affecting the industry. Also, I would like to thank the MSBA Tax Law Section for sponsoring the event, as well as the MSBA Health Law Section for doing it with us. So enjoy the program, and Eric has a few additional.
Yeah, thanks, Vadim. This is Eric Crowder, the chair of the Health Law Section. And while I want to thank our membership and the tax law membership as well, I want to give a huge thanks to our panelists who are devoting their time both during this hour and in advance to prepare for this webinar, prepare materials, and also discuss with each other in order to optimize the experience and the substance of the meeting. So really thank you guys. You've been extremely generous with your time, and we'll all benefit from it. So I'll turn it over to Nancy, and everyone enjoy. Thanks for being here.
Okay, thanks, Eric. Thanks, Vadim, and welcome, everyone. Thank you for joining us today. My name is Nancy Smith. I'm the healthcare partner for Rosen Saperstein and Friedlander. We are a business consulting and accounting firm based in Towson, Maryland. I will be your moderator today, and I will be introducing each of the speakers who will be speaking for approximately 10 minutes or so, hoping that that will leave us ample time for questions and answers. There is an opportunity for you to submit your questions. We will be holding questions till the end of the 4 presentations and then open it up. You will be muted throughout the presentation until the Q&A section at the end. So we will be accepting your questions and then hopefully have ample time at the end of the formal part of the program to go into what we hope is a very active and participative Q&A section. So as I'm sure you know, telehealth isn't new. Remote patient monitoring, some sharing of radiology images via phone lines has actually been around since the 1950s, but it has historically been underused. COVID-19 pandemic changed that with use of skyrocketing telemedicine. The CDC showed that for the first quarter of 2020, telehealth visits increased approximately 50% over the same period the prior year. And in the second quarter, that increase was up as high as 154% compared to the same quarter in the previous year. So in 2021, telehealth is poised to transform how healthcare is delivered. We know in 2020, telehealth was an essential tool to make access to care possible in an unprecedented situation. It was implemented quickly to solve a problem. But now it's really time to look forward, consider what we want telehealth to do for us and how it can impact our health and the business of medicine. So our distinguished panel today of presenters have prepared some really valuable insights that have been gained through their organization's experiences this past year, as well as some important tax, strategic, and legal issues for your consideration as we go forward. So at this time, I would like to introduce Dr. Lisa Figueroa. Dr. Figueroa is a board-certified emergency physician with significant experience in occupational medicine and telemedicine. She's Vice President of Medical Operations and the National Medical Director for Health Information Technology and Telemedicine at Concentra. She received her MD degree from the University of North Carolina at Chapel Hill. And in addition to her clinical work, prior to joining Concentra, she was a principal designer of an emergency department information system and healthcare information consultant for KPMG. So thank you, Dr. Figueroa, and we'll turn it over to you.
Thank you, Nancy, and welcome everybody. I'm very happy to be here today to speak with you all. What I'd like to do is start with, I don't see the presentation on screen. Oh, there we go. If you'll move to the next slide, please. I'd like to start today speaking about telemedicine as a whole, and also with a bit of a focus on workers' comp and telemedicine, because that's what my role at Concentra focuses on, is telemedicine for workers' comp injury care. So let's start first by defining some terminology. And the terms telehealth and telemedicine are often used interchangeably. And we know this, we hear it often. We don't know, folks are saying telemedicine, some are saying telehealth. Where in fact, telehealth encompasses a broad definition of technology-enabled healthcare services. That includes medical care, health education, and public health services. So some examples of telehealth are remote patient monitoring, mobile health or mHealth, as well as store and forward technology and telemedicine. So as an example, remote patient monitoring is the collection of medical and other forms of health data from patients in one location that is transmitted electronically to other healthcare providers in a different location. And this transmission occurs securely. And based on that information, clinicians can assess and recommend different healthcare treatments. mHealth or mobile health, a lot of folks know as patient portals, and that's a great example of mobile health. And often folks that see their primary care clinician or specialist care have access to portals. So that's mobile health, mHealth. Store and forward technologies include electronic transmission of information such as digital images, x-rays, other documents, pre-recorded videos, and this is also through secure email transmission from one clinician to another. And then telemedicine. So if you think about telehealth, we think about other digital forms of transmitting information that I just mentioned, remote monitoring for heart monitors or glucose monitoring, mHealth, store and forward technologies, as well as telephone. We know many, many years ago, 60 plus years now, telephone care for geographically dispersed patients. Those are patients, NASA patients, patients as part of the military organizations in our country. Access care with their clinicians or clinicians via telephone. So think about telehealth in a very broad definition, and telemedicine being a component of telehealth. So telemedicine is the virtual delivery of care that involves video conferencing between the clinician and the patient. So it's a two-way interaction between the patient and clinician. So telemedicine being a component of telehealth being the more broad definition of this care delivery. Also telerehab, that is certainly growing. With COVID, it grew much quicker, but being able to see a physical therapist, an injured patient can manage their physical exercises, their home exercise programs, and really speak to a physical therapist and get them to recovery a whole lot quicker. And a very important thing to remember, and I think this is one of the most important things, is that telemedicine is not a different form of care. It is still just a visit between a patient and a clinician, only the tool to deliver the care is different. So remember that it's not different form of care, it's just a different tool to deliver that care. Next slide, please. Okay, so as I mentioned earlier, Concentra Telemedicine focuses on workers' comp injury care, and what we do with these patients and what we would like to provide for these patients is better stated, is access to care. So when we think about access to care, and folks and patients having difficulty accessing care are typically folks that are remote or that are geographically dispersed, like I had mentioned earlier, or that they don't have access to care in close proximity to where they live, or they're trying to access care after hours when there is no other option aside from perhaps emergency department care. So what we do with telemedicine is we provide that access to care. It's convenient for the patient and it provides them quality care between a clinician and that patient. So it's the same quality of care, but just remotely. A lot of people say, this is really just for those outside of urban, more remote locations, but when in fact, especially if you think about California and that population, it's convenient access. They don't have to get into traffic. They don't have to leave work. They can see a clinician very quickly. They have access to that quality care without having to leave their home or work. And that is one of the most important benefits of telemedicine. Next slide, please. So the types of care that we do with Concentra Telemedicine are injury visits. So those are the initial injuries. And we know that telemedicine isn't appropriate for every workers' comp injury, but those that are appropriate, the relatively minor injuries that would have a benefit to the patient and the clinician, provide a fairly comprehensive virtual physical examination that is self-directed, and the patients are able to see those clinicians for their initial injuries. We also think about recheck visits, and these visits are follow-up visits from the initial injury, as well as potentially visits to discuss MRI results with patients, perhaps lab results with patients. Gives them an opportunity to have that interaction with the clinician, to have their questions and answers presented. Telerehabilitation, I also mentioned, but specialty visits is also becoming extremely popular, and even more so now with the COVID pandemic, and dermatology and behavioral health being amongst the top of those. Bloodborne pathogen exposure counseling and treatment. With our growth in this area with concentric telemedicine is second to none. Think about those patients that get a needle stick injury at work. They're often panicked. They don't know what to do. They want to speak to a clinician. They don't know if they've been exposed to hepatitis B or HIV. This gives them an opportunity to see a clinician provide the counseling, provide lab requisitions so they can get their lab work done, and then see the clinician again to discuss follow-up treatments. If they need post-exposure prophylactic medications, we can prescribe those as well. All of this is done in an EMR so that we are able to do this electronically. And then we have options for patients that miss appointments. We never had more missed appointments than with the COVID pandemic, especially at its peak, where patients were fearing exposure to COVID-19 and were not entering the physical centers and clinics to seek care. So opportunity to see a clinician, maintain their treatment and management via virtual telemedicine. So those patients would not miss those appointments. They would continue to get well and return to work. Next slide, please. So the COVID-19, pandemic, we all know telemedicine was at a certain point and pretty popular in the consumer health arena, but then lagging, I should say, fairly significantly behind with workers' compensation. So with COVID-19 pandemic, concentric telemed, for an example, was seeing about 50 patients a day. And then at the peak of the pandemic, we were seeing over 200 patients a day for just workers' comp injury. So it really threw us into 500% increase in our telemedicine visits. And because folks have smartphones, most people have smartphones and computers within their homes and workplace, the technology was there, and advances in the smartphone technology bandwidth, especially, so that we can have that video interaction, not just telephone, it's video, audio, visual interactions with our patients. So the on-demand access to occupational health care services has never been more important. And we were able to provide that care at Concentra Telemed. We had a centralized core team, and then based on the volume of patients that we anticipated, we advanced our telemedicine offering to all 500 plus of our centers across the US. And we did this within 2 weeks' time and provided that access to those patients that had built relationships with clinicians in those centers. So it became a very important access to care. So next slide, please. So what does a good solution look like for telemedicine? It is a solution that has the technology platform, a platform unlike just Facebook or Skype, not Facebook, FaceTime, pardon, or Skype or other video applications. A good solution has a HIPAA compliant technology platform that allows video and audio. It supports workflows of the organization so that you don't have to redesign or rework your specific workflows. It supports an electronic medical record for the continuity of care, all of the records in one place for the patients, all within an EHR to have that continuity. Actionable reporting, you want to be able to produce numbers for your employers and your and TPAs and billers, and have 24/7 support. Also, and equally important, even more so, is a clinician network, folks that have expertise in occupational injuries or expertise in the care that the patient is looking for, that embrace telemedicine and the technology and are in network with payers. Care coordinators in our organization are the greeters. So the patients don't reach the clinicians directly. They meet with a greeter first, and we call them care coordinators. They get them documented in our systems. They make sure that the patient gets all of their instructions at the end of the visit via secure email, and they also make sure that they have the patient's follow-up information. State forms are also created within our EHR, and that information goes automatically to whom it needs to go to. The communication, very important. We know, especially in the occupational medicine and workers' comp industry, that communication to those employers and TPAs is critically important. Telemedicine solutions that deliver that information the same as if they had walked into a center for care is critically important. So having that communication in place and that communication with the employers and the payers is critically important to a good telemedicine solution, especially for a workers' comp injury in occupational medicine. Next slide, please. So very quickly, I know folks will be speaking about the CARES Act, but the Coronavirus Aid, Relief, and Economic Security Act, better known as CARES, allowed for the expansion of telehealth services. And when I say telehealth, I'm talking about telephone visits, in addition to what I spoke about earlier in the broader definition of telehealth. And it allowed for this expansion with proper billing and access to patients via different forms of technology that would allow that interaction, maintaining the continuity of care, having highly satisfied patients, and avoid consequences from delayed visits. Those injured visits, those patients that are ill, the ones that actually need to be following up with their clinicians, accessing remote monitoring, making sure that they're not lost in the system, and then perhaps chronic conditions would worsen. So I did also mention that the importance of the expansion of this for those folks that feared exposure by being physically present in different clinics, emergency departments, physician offices. So the CARES Act enabled that expansion of telehealth services so that we could provide the same quality of care to these patients. And I believe that's all I have.
Okay, thanks very much, Dr. Figueroa.
My
And
pleasure.
I thought it was very, very valuable to hear firsthand experience of a healthcare organization that had to respond, and clearly Concentra stepped up very quickly and impressively. So thank you for sharing your organization's experience with us.
My pleasure.
Going a little deeper into the weeds, our next speaker, also kind of from an operational perspective from the provider side, Zubair Ansari. Zubair is the Senior Director of Physician Reimbursement for Luminous Health, headquartered in Annapolis, Maryland. Zubair leads a team across 3 hospitals in Maryland with executive oversight of reimbursement, coding, cash operations, and customer service for the professional revenue cycle. Prior to joining Luminous, Zubair served as the Director of Professional Fee Revenue Cycle for the Community Medical Group at the University of Maryland, led the patient financial services for Kaiser Permanente of Mid-Atlantic states, and worked with the Johns Hopkins Medicine International. Zubair has served on the board of the National Association for Healthcare Access, is a trained Six Sigma Black Belt, and is proficient in 4 languages, but hopefully today he will be presenting in English. So Zubair, thank you for joining us today, and we look forward to your presentation.
Thank you, Nancy, and thank you, Dr. Figueroa. Appreciate it. If we can get my slides up there. Oh, great. Thank you, Bill. Next slide, please. So today I'm going to talk, I'm going to give you guys a free commercial on Luminous Health. Hopefully it won't take that long, but we're going to talk really about the evolution of telehealth. I'll try to get into some of the operational considerations that we should consider, and give you a little different perspective from a provider group feel. We're going to get into some reimbursement policies and some trends that I've noticed in the industry, and then we'll kind of end it with some considerations for Maryland providers. So I'll start at kind of like 30,000 feet, bring it down to like 1,000 feet. And then if there's any questions below that, please feel free to chime in all the way at the end of our presentations today. And also kind of end it with some impact that we're seeing in our industry for all of us to kind of take back. Next slide, please. So a little bit about Luminous Health, that's our website. We are 3 hospitals in the Maryland area. We've got 2 medical centers here in Annapolis, 1 in Lanham, so kind of Southern Maryland. We've got about 1,800 clinicians. Of that, 450 or so physician providers, and growing as we expand in the region. We had a little less than 1 million visits last year with all of our medical centers combined. And we provided about $70 million in charity care, which we feel is a strong highlight for us. Submitting more than 800,000 claims from a billing perspective for our physician provider groups. And with an organization that's a little north of, or getting there at least, of about $1 billion a year. So we are what a lot of people may be considering like a medium-sized hospital, but we are expanding, and we just got a new logo, as you can see there, from Anne Arundel Medical Center Times to Luminous Health. So we're pretty excited about that. So check out our website if you want more information. Next slide, please. So definitions of telehealth, and Dr. Lisa did a good job of talking through this. Here, the takeaway here is I just wanted to share with the group that there's a lot of different definitions out there. If you were to ask me 5 years ago, what was the definition of telehealth? HRSA did a good job, and they said it's the use of electronic information and telecommunication technologies to support long distance clinical healthcare, patient professional health related education, public health, and health administration. Well, WHO, or World Health Organization, if you ask them in 2021, what's the definition of telehealth? This is what they came back with. They said it's the delivery of healthcare services where patients and providers are separated by distance. So what you're seeing is this trend where it's not really about geographic distance as much as it could be down the street, it could be outside your medical center, it could be outside your physician office. It doesn't have to be across state lines. So that's kind of the point that I'm trying to say here, that there's multiple definitions out there, depending on who you ask, but it's really, we're getting out of this confinement, and we're starting to look at this as a country versus just maybe a state or a city, or in this case, a neighborhood. Next slide, please. A little bit more about expansion, and Dr. Lisa touched on some of these things. I wanted to share some really cool kind of tidbits about the evolution of telemedicine. 1897, as you can see in my graphic there, Dr. Thomas Wakely, who founded this British journal called Lancet, he talked about, or there was an article in there talking about telephones being used to reduce unnecessary office visits. So think to yourself, more than 120 years ago, this concept of how do we produce telemedicine or telehealth. In 1925, the cover of Science and Invention magazine, I took a little snippet of it and shared it in this slide. They show a doctor actually diagnosing a patient by radio. So in the article is talking about envisioning, devices that could allow for the video examination of a patient over distance. So I thought that was pretty cool. I wanted to share that. In the 1950s, I think in 1956 to be exact, NASA developed this technology with a pilot program with the Papago Indians, the space technology program for rural Papago advanced healthcare. It was called StarPac. So it was a project to try to help in rural Indian reservations. So I thought that was pretty neat. And then if you look at kind of the last 30 to 40 years, slowly telemedicine had a gradual increase, different programs and platforms. And if you look in the 2000s up to the 1920 timeframe, we had more apps coming out like Heal and Teledoc. And then just in the last year, you guys know better than I do, in our country, we've really had to leverage technology more and more in our medical facilities and really connecting our providers to our patients in real time. So I'll talk a little bit about some of the considerations as we dive into details from a coding and billing perspective. Next slide, please. So this is a little bit about growth. So Statistica provided this graphic. And the bottom line here is, if you look at the last almost decade, telehealth on the low end has almost increased by, 350 to 400%. If you look at just the graphic on the right in 2022, they're guesstimating 81 million telehealth visits in the United States. So, and growing. So that's kind of what I wanted to share with this graphic. If we go to the next slide, it's really interesting to see the correlation between volume of visits and adoption. 10, 15 years ago, there was a big push for physician adoption with electronic medical records. Well, now there's a big push for patient adoption with telemedicine. And you can see just in the last 18 months, based on Civic Science's report in June 2020, that almost a 400% increase in percent of US adults who have used telemedicine essentially adopted to using it regularly, from 8% up to 32%. So if you were to take the slide before and this and put it on top of each other, you're almost seeing a direct correlation, exact correlation. Next slide, please. So the next few slides, I'm really going to dive into kind of CMS coding policy and billing from that perspective, and some things to kind of consider. As Dr. Lisa had mentioned, we had the CARES Act last year that's extended our public health emergency since March of 2020. The previous HHS health czar by the name of Dr. Secretary Azar had extended the COVID PHE at least 2 or 3 times into 2021. Another thing on CMS policy is that Medicare, essentially, if you're looking at what's really a big development, is that historically providers would see patients in the office, right, in that traditional setting. Well, now they can see patients and provide professional services to beneficiaries across all areas of the country and all settings. So a lot of the, originating sites, a lot of those things have been waived. So a lot of the providers have taken advantage of that. You're seeing a broad range of clinicians, especially physicians, now able to provide certain services by telephone to their patients. I say certain because I'm going to talk a little bit later about some types of clinicians who are a little restricted to that, even with these waivers. Medicare is paying for telephone evaluation and management visits. So there's certain CPT codes that, and I'm not going to go through each one of those, but they're basically equivalent to what Medicare would have paid for an established patient office visit since March 2020. So some of the things used to be applied for a patient that came in, was established, and then a recurring visit or a follow-up visit would be taken care of or paid by CMS and insurance companies. Well, now some of those restrictions are waived off. And so even a new patient can utilize telemedicine and the providers can get reimbursed for that. So the E&M codes apply to new and established patient visits. Next slide, please. So what's April on an interim basis? They did revise their policy on how to level outpatient evaluation and management visits. In the billing world, we call those E&M. So you'll hear that term a lot in the coding and billing world. So E&M visits have been leveled out. It did not apply to inpatient. So there's still that requirement that you have to see inpatients in person. Although there is some remote monitoring considerations that have taken place. So that are some changes that are coming downstream. Bottom line here, team, is that if there's any evaluation management visits furnished through telehealth, they look at what we call MDM, or medical decision making. So we're really giving a lot of consideration into the physician or provider's decision-making skills while they're in that encounter, especially when that encounter has coordination of care is dominating more than half of that visit from a time perspective. So we do, from a billing side and from a compliance side, we make sure that documentation is clear, that a provider has to say, I spent 22 minutes with the patient, or I've clicked on something that says more than half of my time I've spent with the patient from a clinical or counseling session. Some of these things you can find on the cms.gov webpage. It's all there, it's transparent. And the reminder here is that we really are stressing in our industry the interactive audio visual component, because if it's just a telephone component, the reimbursement is lower and it does not qualify for what we talked about earlier, that face-to-face time. So those are some of the changes. So we can go to the next slide, Bill. Probably a pretty busy looking slide for the group, but I wanted to just share the different types of virtual visits that are out there. The three main are essentially the face-to-face visits as far as a type of service. Then you have, if you're going down with me on the left side, virtual check-ins. So this is really just telephone calls where you're having an audio conversation. So there's a certain type of code that the provider has to use in that instance. And then just e-visits or online brief digital check-ins. They also have their own set of codes. Each of the codes reimburse a little different. So something to consider from a legal standpoint, making sure providers are documenting thoroughly, as well as choosing the appropriate code. Now, I can tell you from our hospital perspective, when this started out, this whole COVID pandemic back in March of 2020, some of these things were not very clear. So a lot of organizations, we thought the most defensible approach was to just treat everything as a evaluation and management service, as a telemedicine visit. Well, back in April, May, June, July, in summer, that's when CMS came back and said, hold on a minute, for true face-to-face, use this. For a telephonic visit, use this. So there was a lot of confusion, but I think eventually the powers that be got together and started creating some clarity. So you will hear this in our industry about, making sure we audit, and I'll talk about that in a few minutes. Next slide, please. Here, the bottom line I want to share with this topic, and Bill, if you could click one more time or a couple times, I think it'll show the graphic. What I wanted to share with the group is that in 2015, and prior to that actually, we had what we call national parity laws. So this is when you're getting reimbursed for live video, the same as you would for a patient walking into the clinic. So just 6 years ago, we had more than 20 states that were not signed on to this national parity law. If you look at just this year, that has diminished down to just 7 states. So we've seen, almost a 200% increase or 300% increase in states saying, you know what, we want our providers to be reimbursed for payment practices in our state. So you'll read a lot about this, and the Center for Connected Health Policy, they have, and I've cited them there, they have some really, really good information. If you want to click by state, if you want to click by geographic region, and really the thing here is that at the end of the day, states do control a lot of the parity regulations when it comes to telemedicine and payment practices. So for example, you might be reimbursed with parity for a face-to-face rate in, for example, like Georgia, differently than getting a lower reimbursement in a state like Colorado, versus not even being covered at all in a state like Wyoming. So just kind of keep that in perspective. I think one of the challenges is, how do we make something that's more equal across the country versus kind of breaking it from state to state? The good news is, I think for providers as well as for clients and patients, is that you're seeing a more increase in national parity laws aligned with more and more states. If you were to look at a similar graph from like 20, 30 years ago, it was far fewer states that were aligned with parity laws. So this is heading in a good direction. Next slide. And then kind of bringing it back to our local, environment in Maryland. What I can say is that just to kind of recap or to think about, for telehealth services, face-to-face truly means audio, video, FaceTime, or a telephone with FaceTime. Once you have that established, that drives the reimbursement for the rest of the encounter. So I really encourage organizations to stick to that. Telephone calls without face-to-face time do not meet the face-to-face requirements. Patients used to have to initiate all of the calls to the offices. Well, providers can contact patients to educate them on service as well. From a legal standpoint, either I've seen some applications have like a checkbox where the patient's saying, I consent to privacy rules. So patient consent for billing is key from a legal perspective. In our business, we always encourage our providers to document thoroughly. I remember ever since my days, and I'm not an attorney, I have a lot of respect for attorneys. I remember when I was in mock trial back in high school, there was a big push for make sure you document. So I've always heard that from my legal friends throughout my life. So I want to reiterate that. Make sure we document. It is the most defensible approach. Some provider types, I talked about this earlier, they cannot see patients out of state. So in our state of Maryland, the Association of Physical Therapists in the state of Maryland has decided, the statute is that as a physical therapist, you cannot see a patient that's located out of state. So I just wanted folks to know that this is not just a one size fits all. Some associations have language that doesn't clearly allow or say that this provider should be able to provide services to an out-of-state client. So that's just some of the things that we need to consider as a state of Maryland. Next slide, please. How can I give a presentation without talking about dollars? So I'm not going to spend a lot of time on this slide. I think the takeaway here is that if you just look at Care Journey's article here, we spent in 20 about $2.5 billion on telehealth utilization, 10 million unique patients, which is just amazing. And then about 500,000 unique providers that really utilize telehealth. It's growing. If you were to look at this same graphic, I'd say 2 or 3 quarters from now, a lot of these numbers will probably double. So just wanted to share a little slide about dollars and cents as far as telehealth visits. Next slide, please. And then future impact. So reimbursement methodologies are evolving. If you look at what CMS is proposing in a lot of the language and buzz that we hear about in a lot of different areas, they're talking about, for example, kind of going back to that traditional sense where, and some of the payers are doing this as well. So remember, one note to keep is that you will notice a lot of the payers like the Care First and the Aetnas, they follow at times CMS policy. So when CMS comes out and says, we're gonna start thinking about doing this, trust me, those other payers are thinking about doing the same thing. So one of the things, for example, is like your first visit in a clinic should be in person. And then any subsequent visit or follow-up would be a telemedicine. So we might see a lot of the reversals of those waivers in the future. Knowledge and expertise. When you think of telemedicine, we think historically, when I shared the history, you think of like rural communities. Well, guess what? It's happening even in urban, larger, medium-sized cities as well. So just be cognizant of the fact that a lot of the waivers cover telemedicine services, even in those larger communities, even though historically it was really tended to be for those low population rural communities. Complexities of the healthcare industry and driving customization. This is where I think I am noticing a big trend towards, for example, like mental health and behavioral medicine, really offering those type of services. You're going to hear a lot more of that. I see OB services. And when we talk about remote monitoring, so there's a trend towards, for example, offering our neonatal patients something that they can monitor at home, and insurance companies are paying for that. So those are just some of the things as far as a future impact. And then expect increased audits. So maybe some impact to our legal world is kind of like OIG, CMS coming in and saying, you know what, we want to look at a few RAC or MAC audits that are dealt specifically to telemedicine. And we're seeing some of that. So just be proactive. I encourage providers to be proactive and document, especially on those, when I talked earlier about evaluation management codes, the level 5s. So level 5s is really, spending quality time with the patient and going through everything like history and complex scenarios and making sure we sign off on that. I think that CMS and insurance companies are really going to critique the level 5, which is like the highest level for reimbursement on a lot of our visits. We, in our organization, we've actually set up like a workflow. So I'm sharing some operational expertise here, where if a provider codes anything that's level 5, I have a team that jumps into a bucket and we review the documentation and push back if necessary. Because what I don't want, we have to protect the institution. What I don't want is CMS or OIG coming back and saying that it's really important that you make sure that you are reviewing the documentation to ensure that it really qualifies for a level 5.
Excuse me, Zubair, I think we're going to have to break in just to give our other 2 speakers, because we've got both tax and legal considerations. So thanks so much.
Yep, you're welcome.
I think we do have to move on. Next speaker is James Eaton. James is the tax partner with the SC and H group in Hunt Valley, and has extensive background servicing real estate clients, pass-through entities, high net worth families. James has taught as an associate professor, guest lecturer at Johns Hopkins, Towson, and Loyola. Sorry to rush through his intro, but we do want to hear from James, so I'm going to turn it over to him. Thanks.
Hi, everybody. I'm a tax guy, so this should be really interesting. Okay, eyelids open. All right, everybody, eyelids open. So I think in our 10 or 12 minutes, we just want to run through some general considerations for businesses, because while at the end of the day, we're all talking about telehealth, just like they say when you get on the airplane, right? They say if the oxygen thing comes down, you have to protect yourself first, and then you have to protect the people next to you. And so if we can't keep healthcare businesses in business, then they're not going to be there to help people. So an interesting statistic is that I think according to Brookings and the Tax Policy Institute, more than 95% of American businesses are flow-through businesses. That means they're sole proprietors and they're S corporations and they're partnerships. So anything you watch on the news and you hear people talk about, oh, corporations do this and that, something on the order of 3% of the businesses in the country are corporations, and most of them are really pass-throughs. And oftentimes, certainly in our client base, taxes can be the 3rd or 4th or 5th largest cost segment. So we want to be thoughtful about those. So a real quick disclaimer. We're going to talk about some technical items. Oops, if we want to go to the next slide, we'll see our disclaimer here. They shouldn't be treated as tax or legal advice. Just a tax guy trying to tell jokes, okay? Next slide is a picture of me, an embarrassing picture of me, and my contact information if you need me. So if ever we can be of service, give a shout. Real quickly, what are we going to talk about? Teleworking. Teleworking is the future. Let's think about what that means from a business perspective, from a tax perspective, and from a compliance perspective. And then we'll talk about considerations for employers, right? For companies, really important. And to a lesser degree, maybe a lesser degree, for a lesser degree for companies, for management, is considerations for employees. But I guess at the end of the day, human capital is maybe the scarcest kind of capital. And so we do need to consider what are the considerations for our employees, and maybe what kind of communication should we keep in mind. All right, so our next slide is telework, right? The future. The really interesting things we've been seeing this year are questions like, when does sheltering in place or working from my beach house become, I'm now a Delaware resident, right? And then when people get clever and they start thinking, hey, if I'm a Delaware resident, I can work from home. How long do I have to spend in Florida in order to be a Florida resident? And I think talking to a room full or a virtual room full of attorneys, it won't surprise you to know that this could open up all sorts of questions, not the least of which is when we talk about our previous presentation about rules and what is in person and what is billable in certain ways. Maybe licensing and reciprocity could be impacted by where a person physically sits in the healthcare industry. And from a business perspective, we also look at that and say, hey, what does that mean for the company? If a number of my employees on the operation side and maybe even in management are working from home in Delaware at the beach or in Florida at the beach, does that mean the company has situs in those places? Do we have a filing requirement? Do we have nexus? These are some of the considerations we have to think about. Now, COVID, like so many things we've just talked about for maybe 40 minutes, about how COVID has forced regulators and legislators and businesses, HR functions and businesses, to be more flexible with respect to working with employees and letting them work from home or work from different places. And that's all great. An HR function is maybe really good at that. But then when you come back and I tell you that, hey, the tax guy called and he said that all 10 of our partners, all 10 of the docs that are partners in our business now have to file in 4 or 5 states their individual income tax returns because it's a partnership, that's really can be trouble. Also, you have this idea, and more than a few folks have run this by us, of, hey, I don't think my boss would approve of me moving to, again, let's just say Florida, Tennessee, Texas, someplace with lower taxes. But I'm going to do it anyway. They won't know the difference. And I'll ask for forgiveness instead of permission. And that can cause lots of issues. But to some degree, do we have to be thoughtful as businesses about things that our employees do about which we're not even aware? All right, so macro, we'll look at considerations for employers, and there'll be a lot of words on this next slide, but we're going to try to move through them briskly and be sensitive to everybody's time. So some of you attorneys out there will say, hey, somewhere in my law school background, I remember this public law. It was public law PL 86-272, and that should mean that if my only activity in a state is essentially admin or sales sourcing, that I shouldn't have nexus in that state. That's probably true. And I would say to you, good memory. But an important thing to remember is that's income tax nexus. So you could still conceivably have sales tax nexus, or maybe more pertinently for this discussion, payroll tax nexus. So if you have somebody, and this seems to be more and more common, I get a call about this every 2 or 3 days. Hey, I have one of my people and they moved out to Denver for the summer and now they're not coming back. When do they become a Denver resident? When do they become a Colorado employee? When do I need to sign up for Colorado unemployment insurance and withholding accounts, and maybe even workers' comp at the state level? That's something you really have to look at on a state-by-state basis, right? Some states are being more and more flexible, some states less so. Maybe not surprisingly, New York, Massachusetts, and California are some states where we're hearing maybe not horror stories and maybe not yet, but we are hearing things like that New Hampshire is suing the state of Massachusetts over its situs rules. So Massachusetts is saying, hey, if your normal office is in Massachusetts, you're going to be treated as if you're doing your job from Massachusetts, regardless of where you actually are. And New Hampshire says, hey, if you want to come over here in New Hampshire and work from home, that's great. You're a New Hampshire resident, couldn't be happier for you. The problem is the business or the employee could be caught in the lurch where there is actually a possible exposure to double taxation, where Massachusetts is not going to give you a credit and New Hampshire also wants to tax you. And also some of these states we have to look at convenience of employer versus convenience of employee. So New York has some specific rules. It says if your employer tells you to come stay home, right? Certainly in the city, this is something that hardly anybody lives in the city and everybody lives in New Jersey or Connecticut. If your employer tells you to stay home, that's one thing. But if your employer gives you the option and you choose to stay home, then New York is still probably going to want to source the employee's income and the revenues to New York. So those are really detailed sort of analyses that a larger company needs to look at. Certainly in our geographic area where you have DC, West Virginia, even Pennsylvania and Maryland, maybe Delaware, all within a day's drive. And certainly in the healthcare industry, hey, look, my wife is a nurse. She knows people that live at the beach and drive, and kind of stay overnight or, we'll get a hotel room or something like that to work, in Baltimore or DC because the prevailing wage is so much higher. So these are things we really have to consider in a telehealth world. And then I guess maybe lastly, if you have admin and billing folks, are those considered sales folks or are those considered ops folks, right? That is essentially your revenue generation model is that billing. And so if you've got folks that say, hey, I'm going to do a lot of billing, but I'm going to do it from a state in which your state doesn't have reciprocity. So let's just say you're a Maryland company and somebody moves to North Carolina, or somebody moves to Tennessee, a state that's not contiguous where we don't have reciprocity. Are you in a scenario where all of a sudden you're going to have some filing requirements in those states that the company and its owners were not prepared for? All right, lastly, let's touch for just a couple minutes on things employees need to consider. Again, they need to think about, hey, when does working from my vacation home turn into working from my home, and to whom do I communicate that within the company? Also, if you cast your mind back to tax reform that was implemented, passed at the end of 2017 and implemented at the beginning of 2018, there used to be a rule that you could deduct working from home expenses as an employee to the extent they exceeded 2% of your adjusted gross income. Now, I will tell you that in that regime, it was hard to get over 2% of your AGI, and that was subject to the alternative minimum tax, but I digress. In any case, people are still thinking, hey, I'm going to work from home and I'm going to deduct all my home office expenses. Unfortunately, that deduction has been removed from the tax code. So that's not a deduction anymore. And so people aren't going to be able to write off deductions for their home. Now, if they're independent contractors, that's different, but for employees, they don't have that option. Hey, when do I need to tell the payroll department about this change? This is really the biggest change, that employees need to think about. Broadly speaking, and this is not from a legal perspective, it's from a logistical perspective. Broadly speaking, the state's going to hold you to your W-2. So if I move to Florida, and that's great, but if my W-2 still says you made $20,000 and your withholding is Maryland and your income is allocated to Maryland, even if I file, or don't file as a Florida resident, the state of Maryland thinks I've got wages that are applicable to Maryland, and I'm going to have to get in a fight with them. And broadly speaking, the state of Maryland's going to say, hey, if you don't think your wages should have been applicable to Maryland, call up your employer and have them amend your W-2. And you can see where that's going to cause us trouble. So in deference to time, I'd like to say thank you. And I'd like to remind you that this wasn't legal or tax advice. It was just some things to talk about. And that we'd be happy to chat if you have any questions. So feel free to reach out.
Well, thank you, James. Lots of issues there for consideration. And I hope, sorry, we are running late, but I hope you can stay with us for our final speaker, Christopher Dean. Chris is a principal with the law firm of Miles and Stockbridge in Baltimore, Maryland, represents hospitals, physician groups, other healthcare facilities on a broad range of regulatory and traditional business law issues. Chris graduated from the United States Naval Academy, received his law degree, summa cum laude, from the University of Baltimore. Chris, I hope you can stick with us too, and we will take questions at the end for those who can remain. Thanks so much. Chris?
Thank you, Nancy, for the introduction, and thank you, Dr. Figueroa, Zubair, and James for teeing up this discussion. So my discussion is going to be about telehealth from a Maryland legal perspective. As I often tell my clients on phone calls or Zoom calls, I'm the Debbie Downer in the room. Everyone else talks about what they'd like to achieve, and then I talk to them about what the law says they can achieve. Unfortunately, the law tends to trail technology. It tends to trail business desires. It tends to trail consumer sentiment. Consumers seem to be now more embracing telehealth. They'd rather wait at home in their pajamas than wait in the waiting room of their doctor's office to get care. So that's where we are today. And we're going to talk about telehealth from Maryland law, recognizing that there are different drivers and different perspectives as to what things are doing going forward. So my first slide will talk about an introduction to what I'm going to cover. We just talked about the general legal issues. We're going to talk about tele what, and this is more in reference to what Dr. Figueroa was talking about. There are many different ways to look at telehealth. And so before 2020, I would argue that telehealth went forward in different steps from different stakeholders in different fashion. We'll look at telehealth in the 2020 general session. I think the law coming out of the session this past year really set apart and set a floor of what telehealth is and should be going forward. We'll talk a little bit about the governor's executive orders as they vary in COVID-19 and telehealth and things going forward. And then lastly, I'll open up the crystal ball, which tends to be cloudy most of the time, as to what could impact Maryland law and telehealth going forward. I'll tend to stay clear of the Medicare issues, the national issues, and really focus on the Maryland issues. Like every good CLE offering, there has to be definitions and citations. I'll try to present definitions in a fashion that are contextual and not reciting them word for word verbatim. You'll see citations in the bottom of the slides where applicable. These definitions came out of the Board of Medicine's regulations, not because I think they're better or worse. They were in existence before 2020, and they tend to be generally similar across the Board of Medicine, the Board of Social Work Examiners, et cetera. So we'll talk about telehealth, what's not telehealth, who a practitioner is, and then the distinction between asynchronous and synchronous care. According to the Board of Medicine, telehealth is the interactive audio, video, or audio-visual communication of health services. It's not a phone call. It's not an email exchange. It's not a facsimile. And it requires a licensed physician or allied healthcare practitioner acting within the scope of their practice. If you're not licensed in Maryland, or you're doing something outside of your scope, you shouldn't be doing telehealth. So for example, if you're a physician assistant and your specialty is in physical medicine and you do pain management, you shouldn't be doing eye exams over telehealth. It's outside of your scope of practice. And a little bit about synchronous and asynchronous. Obviously, we've talked about the difference between the two modalities. From a general sense, synchronous telehealth seem to be more readily embraceable by the professional boards. They seem to get a better understanding about what it took to have a simultaneous conversation between, say, a physician and a patient, where you're allowed to go through an interaction so the professional can reach a point of their judgment to decide on a modality of care and a diagnosis. They had a harder time, I think, with asynchronous care, even though things like remote patient monitoring, it is the essence of the care. It's about collecting and pushing data forward that gets evaluated at a different timely basis. So from a sensitive perspective, and this may not be entirely accurate, synchronous telehealth seemed to be embraced. Asynchronous tended to be the smaller brother or sister that got ignored, but was gradually accepted as an exception to the rule. And so let's fast forward to 2020, the abridged general session. It came upon a very unique time. The session didn't run its full course, but there was a telehealth bill. And the telehealth bill really was timely. It's been advocated for in the past. It really was, the goal was to establish a baseline of telehealth in the state of Maryland. The telehealth sections are codified in section 1 of the health occupations article. Imagine a book, which we still have. You open up the book, the very first section has telehealth. So it's important, it applies to all. And so the approach here that the state is now taking is that we're going to take telehealth, and rather than have a profession by profession approach, we're going to establish a floor, a baseline. Telehealth now is applicable to any professional who practices under the health occupations article. It's no longer going to be a board by board determination. And we're going to explicitly say that asynchronous telehealth is permitted. So rather than allowing boards to wonder whether it is or it isn't, we're going to go ahead and establish a baseline of care going forward. Now, having said that, there were some exceptions to the bill. We didn't allow telephone calls, facsimiles, emails still, and we didn't allow prescribing opiates, but there was an amendment late in the session that recognized that the COVID emergency was happening. And so the governor was allowed to permit prescribing opiates if there's a state of emergency, which was, obviously was coming down the road. The Assembly did a nice job of reacting to the reality of the situation. The telehealth statute also established a new standard of care, but I use the word new in quotations. I don't really think this is all that new. This seems to be what you would do if the patient was in your office, right? You can't give care unless it's medically appropriate. You can't give care if it's outside of your scope. Again, that physician assistant shouldn't be doing optometry tests if he's a pain management physician assistant. The telepractitioner also has to communicate some information back and forth with the patient. You have to verify who the patient is. You would do that if you walked into the office. You have to tell the patient who you are. Your license should be on the wall. You tell them, I'm licensed, so and there's my license number. And then curiously, you have to get patient consent. I'll come back to that later. It's a curious, I think, aspect that does with the newness of telehealth. And then lastly, the telehealth care has to be the same care that they would get in person, which I think is consistent with what you've seen from other people talking today. Next slide. Again, talking about the floor, the bill made very clear that the boards could have their own regulations. We have something called implied authority and explicit authority. Here's the explicit authority, make your regulations, but you can't deviate the standard of care. So telehealth is health. It is health. And then you can provide a process for establishing the practitioner to patient relationship through the telehealth process, which gives them a little bit of leeway to specialize what's applicable to their profession. You can imagine physicians have a different set of needs. Acupuncturists may have a different set of needs. Physical therapists, a different set of needs. So let's move forward. Some examples here, you can look at these later, some examples of how the boards are dealing with the telehealth regulations in their approach. Next slide, please. So the emergency order I want to talk about the most is the one that came out on April 1st of 2020. It actually came out 2 days before the general session law was signed into law by the governor. So there's a little bit of time travel you have to do back and forth between the two standards. And I think the most important thing when you're reading these orders is to read the whereas clauses or recitals as we call them in legal language, because they do a really nice job of setting out what the governor is trying to accomplish. In this particular whereas, it talks about how we want people authorized by law, which includes the order to provide services. We want to allow audio-only conversations to qualify as telehealth. And we want to have telehealth to be the same as it were as an in-person delivery of care. And you see it's in the language of the whereas clause. Next slide. And on this slide, you can see, again, we're talking about how we want audio-only calls. We want to do this to promote telehealth care, and we want to make sure that the access to care is available to people across the board. And these executive orders are important. They dovetail along with the session law that was about to be signed into law by the governor. Next. And so the meat and potatoes are the telehealth order says that audio calls are telehealth. So now we get to the point where the governor's proclamation now matches in lockstep with what Medicare is going to permit for telehealth. Asynchronous telehealth is not clearly permitted. It would have been permitted when the session law was passed and signed, but remember there was a gap in time of several days, so we had to move forward as fast as we could. Sadly, if you have a fax machine, I don't. It's still not telehealth. Emails still aren't telehealth, and so you have to deal with that on a case-by-case basis. Next. We talked briefly on the previous slide about restrictions of practice. The governor's order allowed adjoining states, people who were licensed to be telehealth practitioners. There's your legal basis to allow other practitioners to provide care. A very broad, sweeping move that really has been a touching point for the boards on how to deal with out-of-state practitioners entering Maryland electronically to provide care. And then lastly, the governor's order took advantage of the loophole that was created by the session law, which would have been signed 2 days later to allow the prescribing of opioids, as long as you did it in accordance with the regular requirements under federal and state laws that apply to controlled dangerous substances. I'll just touch very briefly on Maryland Medicaid because I want to move on to other things. As you can see from this slide and the citation below, the Medicaid Medical Assistance Program issued a bulletin that explained that patients' homes could be a site of receiving service. You would bill it as a regular telehealth claim. You would use a special modifier, but otherwise the care would have to be consistent with other telehealth requirements. All right, so what's next? What happens post-COVID? And this, I think, is the most interesting point and perhaps the talking point of where we go forward. Obviously, the 2020 session law, it's good law. It remains law. It moves forward. It sets forth a nice baseline for telehealth to move forward as health and for the boards to move forward telehealth for their profession. What happens with COVID-19 expansion? I don't know. Every time I think there's going to be a deadline 2 or 3 months from now that they're going to cancel the emergency order or not renew it, it seems to get pushed 2 or 3 months later. My crystal ball is not that accurate. So the expansion remains in place and it will be for some time to come. What other things could be driving on telehealth and state law? Interoperability, perhaps. There's been a big push in the national level from OCR, CMS, and the Office of National Coordinator about interoperability, allowing patients access to their data that's being held in various different healthcare providers. I don't think that the telehealth law that was passed in 2020 really touched upon it, and maybe in a rush, Maybe as things evolve on a federal level, there may need to be some tweaks as to what's in the state law. We'll just have to see. I think that we'll see a homogenization of approaches from the boards. They still have to struggle to figure out, do their current regulations, the Board of Medicine, the Board of Social Work Examiners, do they meet the requirements or not? Do they need new regulations? Do the other boards need to come up with their own regulations? So I think that there's going to have to be some thought on a regulatory level in front of those boards as to what happens next. And what about application programming interfaces and patient-driven data? Data coming from people's iPhones and their Androids. How do we deal with that? How does that fit within telehealth? How does that asynchronous data really fit within to the telehealth perspective? And it's a complex area. It's a growing area. Technology is going to exceed the law's capacity to regulate it. Zubair talked about this in detail. Who's paying and how much for telehealth? What are the costs of providing telehealth? Will it cause a drop in administrative costs overall, or will it be more expensive as people have to invest in technology? I don't know, right? But obviously the parity laws are out there and it impacts overall payment. Remember, parity doesn't mean that you get to ride on the backs of other people's costs. It just means that your costs are bundled with everybody else's. And so it weighs against the whole. And then my last one, I think it's curious, and maybe there are experts out there who have another, why is there a need to get a separate consent for telehealth? If telehealth is health, why is there a need for a separate consent? From a legal perspective, when a patient wants to establish a patient-physician relationship, they walk in the door of the doctor's office, they say, you're an expert in this type of medicine, I'm a patient, I'm sick, I want your care. So if the context already initiated at that moment, there's already consent. So why is there a need for separate consent? I think it's really because telehealth is new and we want to make sure that people are understanding what this newness means. It'd be nice to get to a point where you don't need the separate consent, because reality is, if telehealth is health, what's the fundamental difference? If they presented for care to the physician or to the therapist or to the social worker, they've already made the overt act to establish the relationship with the provider. And I turn it back over to Nancy. Thank you very much.
Well, Chris, thank you. That was really excellent. I hope you've been able to stay with us. I want to make a couple points that we have recorded this entire session. It will be made available to you, as well as the individual slide presentations of the 4 speakers. I don't know that I see any questions, but one that I had was, maybe Chris, you could respond. I've been reading that there's an expectation that there will be an increase in malpractice cases post-COVID and with telehealth. Have you any thoughts about that, or have you heard anything about that?
That's an excellent question. I don't normally practice in their malpractice defense. In talking with my clients, there's concern. I think it fundamentally boils down to, are you able to give the same level of interaction with the patient to provide the appropriate level of care? And so that's why there's a lot of force and driving behind state laws to absolve liability and risk for providing care during the pandemic. And it'll become a legislative issue, and maybe it happens and maybe it doesn't, but I think the provider community really wants some kind of protection from liability from providing care during a pandemic executive order when they really could have chosen not to. So.
Dr. Figueroa, any thoughts about that?
Yeah, I think that practicing within your scope is very important. So I think those visits that we see, that if there's a concern about the patient's acuity, that telemedicine or a telehealth visit is not appropriate for that visit, then you need to take that patient and say, you really need to be seen in person for this particular complaint or issue. I think the clinicians just recognizing when an in-person evaluation is necessary will minimize those risks.
I also wondered about trends in M&A and IPO, wondering whether our panelists think those will continue as a result of telehealth and the COVID environment. Certainly there has been a lot of action in that space in the last couple of years. James, you have any thoughts on that?
I think Yeah, with the cost of capital, the cost of lending being as low as it is, yeah, we foresee continued activity in the M&A space. We concentrate broadly in the $5 to $50 million range of enterprise, and those companies are, yeah, absolutely looking at M&A. Not the least of which reason is we've got folks who are maybe in their 50s, business owners, docs in our case, that were in their 50s the last time the economy went south, and it took them 7 to 10 years to recoup a lot of that value. And now they're not sure they want to, you know, they're in their 60s now, and they're not sure they want to see something drop again and then have to work for another 7 to 10 years. So you have, I think, both qualitative and quantitative reasons that are pushing people to consider exactly that what I'll call a liquidity event, right? The opportunity to get out of business and into retirement.
And then, of course, you have the PE firms who have the funding and see the healthcare space is very attractive. So
yeah, I mean, go look at Bitcoin or go look at GameStop or look at whatever else. There is way more money than there is good assets to buy. And so we're seeing even there's some sort of technical term in the stock market, but essentially we're seeing in the debt markets, lenders calling up companies and saying, we're sitting on some money, would you please borrow it, right? And so lending costs are extraordinarily low. And again, there are qualitative and quantitative reasons. And, you know, I think when we look at the comorbidity of how COVID works, older docs don't want to be in hospital environments exposed to these things, right? So if I can get some money and I can go away and I can not have to work anymore and I can be safer, when you overlay a lot of these macro concepts on cheap money and the business environment being what it is, and heading into a structure where everybody's thinking we're going to see higher capital gains rates in the future, you know, capital gains rates that go up to the ordinary tax rate for folks making over $1 million, that could very easily be 6 figures worth of tax to a doc looking at a sale transaction. So we're seeing a lot of both, again, qualitative and quantitative reasons why people are trying to get out.
thank you. Any other questions, comments? I think it's 12:15, probably a good time to wrap it up. Thank you everyone for joining us today. I hope this was valuable. Thank you again to our speakers, and please feel free to contact them to follow up on any of the issues that were raised today. We really appreciate having you. Thanks so much. Bye-bye.
Bye-bye.